Dr. Anthony Fleg is a family medicine physician at UNM in the Department of Family and Community Medicine and the College of Population Health. Originally from Baltimore, Anthony grounds his healing work in undoing racism, health equity, and with a focus on strengths and holistic health. He also co-founded the Native Health Initiative, a love-grounded partnership, and has dedicated much of his career to improving health in Indigenous communities. He is a proud father of 4 children, an avid runner, and a writer and blogger. He has just released his second book, Writing to Heal, The Journey Continues. With that said, Dr. Fleg, thank you very much for joining us today, and the floor is yours.
Sounds great. Who's ready to have some fun? Just raise your hand or smile at me like Jennifer is, and Holly is, and Leandrita. Even Mario's ready to have some fun. Samiria, who I'm wondering maybe you're in the Española program, and UNM Santa Fe residency. Awesome that you all are here. Oh man, Samiria, you're driving too. Okay. Well, don't have too much fun. I want you to have safe fun here. I am excited to share a little bit with you, raise some maybe deeper questions about the work we do, and rush off to see patients as is the life. So take a moment, if you would, with me and just settle into your car seat, your chair, etc. Close your eyes and give yourself permission for the next 60 seconds to just be, to slow down, to deepen your breath, to let those thoughts just sort of waft away and go where they're meant to be, but not to bother you or overwhelm you. All right. I also will invite you to, I'll do my best to see if hands are raised. I like small groups from that standpoint. And also you can put things into the chat as we're talking. Tell us something that's made you smile today. Put it in the chat if you wouldn't mind. Unless you're driving a car, in which case do not put that into the chat. I'm just going to keep picking on you, Samaria. So strength-based medicine is our topic today, and it truly is a new lens for seeing people in communities. If any of you have, over the last decades, been in a workshop with me at New Mexico Public Health Association conferences or other places, hopefully this is a refresher, and I'm sort of going to assume at the outset that we all actually have very deeply the values of being strength-based. I just think that we then fit into a system that is asking the opposite of us. And so I hope I'm going to ask you to flex a muscle that our normal medical system doesn't. If this arm is, deficit work and being really good at pathologizing everything and everyone that comes within 6 feet of us, we're great at that. And then if strength-based work over here, it's the atrophied muscle that sort of fell asleep starting early in our health professions training and in our practice, where it's all about RVUs. It's about, did you code and bill for the pathology of this human being? So acknowledging the traditional Tiwa territory on which I'm sitting here in Albuquerque. Objectives, I want us to sort of define strength-based approaches to health, and also known as asset mapping. I'll be sort of using those interchangeably, discussing and talking about specific ways that strength-based work can be incorporated into your healing work, and also into both clinical and community interactions. Have some fun learning with our hearts. I'm a big fan of learning with the heart. So very briefly, I'm a family physician, married into a Navajo family. As it's matrilineal, I'm sort of lucky to be welcomed into this family as opposed to being the head of the house. My wife is from Tuba City, Arizona. We have 4 children. I'm passionate about supporting our rural workforce, including at the level of residencies. I probably saw some of you at the RMTC conference in Santa Fe just a few months back. And I once upon a time was a National Health Service Corps scholar. Then I did my residency in family medicine here at UNM and was at a FQHC first choice. After UNM, did my National Health Service Corps sort of placement at ACL, facility that serves Acoma, Laguna, Pueblos, and Canyoncito, also known as Tohajilet. I have worked then at Pueblo of Sandia, sort of right on the outskirts of Albuquerque, but sort of a rural feel to it, and currently the Pueblo of Laguna when I'm not at UNM. I'm known to promote movement, and just as part of my sort of extension of my work I more and more say that I'm a community organizer who happens to be a physician, and creating community through walking and running and movement is one of the ways that I do that. And a program that we've started called Running Medicine that is located in a few different tribal communities. In fact, if anyone is here from Gallup, yesterday a running medicine group in Gallup sort of officially launched. But families moving, if you look at the background of this picture, that's the real important part. It's the aunties, the uncles, the tias, the abuelas, all moving and actually running barefoot with their kids. The kids are great. They love playing, they love running. It's when you get the whole family and sometimes 3 or 4 generations together moving that really special things happen. And sort of connected to the topic of turning a new lens, a strength-based lens. I love this quote from one of our participants in the running medicine program. It might just be sort of like a self-check. In the last month, have you paid any attention to historical gifts, your own family, your own community, and your patients, compared to how much time you've maybe thought of trauma, historical trauma, your family's trauma? And so I think our world just orients to the negative. There's even like a human instinct that is sort of that we for survival reasons are more likely to gravitate to something that's negative. Look at any front page that comes up, msn.com, and you'll see 98% of it is negative. The positive stories doesn't attract, in their case, traffic or money. So about 30 years ago, John McKnight and some colleagues, pretty sure John McKnight is a social worker, and social work definitely has been, along with maybe public health, in the health professions fields, more interested in thinking about strength-based approaches. But John McKnight and colleagues wrote a book, ABCD, Asset-Based Community Development. Again, assets and strengths sort of used interchangeably. And this quote to me is really sort of striking. And even though I've read it for decades, it still sort of hits me. um, it's saying something powerful about our lens with which we do the work, and that we can be part of the problem if we're doing that work in a way that is deficit based and therefore requires a patient or a community just to be dependent on us or on the Department of Health on larger systems. And this last sort of line, masked by service, because I guarantee that every one of us does our work and went into health fields with service being, a core service to our community, service to the underserved, service to rural New Mexico, all of it. But that's not enough is sort of, I think, for me, the gist of that quote. So I'd love to sort of ask you to put in the chat, or if you'd like to unmute and actually share an answer to, I asked you what made you smile. And by the way, now I get to look at these answers. Nice. Good answers if you haven't seen the chat. Let's have fun with this first question. Put your answer into the chat. Where are the areas that health and wellness is flourishing at the moment? And if Santa Fe residents guys wanted to unmute as a group and have a few people share, that could work. Or you could.
I'm grateful less than 3 bodies are hurting.
Say that again.
I'm grateful that less than 3 of my body parts are hurting today. Me too.
Okay. So think about this first question for a moment. Where is your health, your wellness, maybe your self-care practice? Where is it flourishing? It's not something that we probably think about enough, even on a just personal level. We're much more likely to complain to ourselves on our Facebook page, to our colleagues, to our loved ones, to our pets if they listen to us about what's wrong, what's hurting.
I've been on a quest for years to get my sleep right. It never really recovered, I think, post-residency. And so the last few weeks, it's actually been getting much better. So I'm seeing some positive movement in that area.
Great. Leandrita, do you mind if I pick on you for a sec?
Sure.
Don't worry, it's going to be a good picking on.
Uh-huh.
So let's just imagine that I walked into the room, you were my patient, and instead of the knee jerk, what's wrong, Leandrita? Tell me what's bothering you. Even tell me why you're here today, which is sort of a it's a cover question for tell me all the bad things. What if I came in the room and I said the exact question that you just beautifully answered? Leandrita, great to see you today. Where is your health and wellness flourishing? And then you start talking about what you just shared of this long journey to get better sleep. And so to make this real, I might ask you one further question, like how do you think that might change our visit, regardless of the 3 or 4 things that you do have on your list or the 4 or 5 things that I might have on my list to bring up with you? Like, how do you think that opening question that's very strength-based as opposed to where does it hurt, what's wrong, let's talk about your out of control blank. How do you think it would change just your kind of experience and what you get out of it, out of our visit as the patient in this scenario?
I think I'd feel empowered because I would automatically be thinking more positively. Even though I may have some aches and pains and other things to talk to you about. It's like, oh yeah, like there is something that's actually working right now. And so I think when you start the conversation from that perspective, it can just add a note of positivity and empowering, I think, to the whole interaction.
Yeah, thank you. it might come back. For instance, there might be an area of your life that 10 minutes later we're talking about that you're really struggling with, and I use as the provider the fact that you've just overcome this big thing to sort of help you see, no, it's not hopeless. Like, we can get your blood pressure under control. We can get that foot pain. Look at what you've done with your sleep. I mean, yeah, it was a long journey, but you didn't give up on that. So there's so many ways that from just the empowerment and feeling like I'm not immediately from, question one, what's wrong? Where does it hurt? I'm sort of put on the defensive, or you're even worse, like, why is your A1C so high? I see your blood pressure is uncontrolled today. All the things we do inadvertently that really take what could have been a much more beautiful human to human interaction and make it a provider, the patient. I only see you as the labs, the vitals, the meds, the addictions, the health conditions. I had a patient recently say to one of my students, I'm not as bad as you would think if you looked at my chart. Well, great. Don't look at the chart. Talk questions like, what are you grateful for? And some really beautiful things happen. And part of it, here's the secret, Mario, when we're talking about, like, why am I here in this beautiful room with these great group of people? It's that I think ultimately it makes the practice of medicine and retention and us not getting burnt out and us not wanting to quit altogether and work at Trader Joe's. Like, if we see whole people and we get the joy of asking these kind of questions and forget the coders and billers and people at our necks for more RVUs, because unfortunately, yeah, the medical system doesn't have a place to put flourishment or where or gratitude. I feel for those. So unfortunately, I am going to have to do real medicine. And I promise you, this doesn't take long. It just enriches the practice of us being providers. It makes us more effective clinicians. Now, that Dr. Fleg is really as excited at celebrating something that's going really well in her health. And he's not just there to attack the 3 or 4 things that he thinks she needs to fix, or the 4 or 5 things she does want to fix. Those are all going to get addressed in the visit, but it's in a context that is very different. It feels different. It feels different from the provider. And if we did this as a role play, and I encourage, like, the residency that's here, I'd encourage you to actually try that out as a role play, but not only focus. Usually when I do the role play, everyone's expecting me to ask, what was it like to be a patient in that? And yet that's important, but I also really want to hear, what was it like? How was that different to be a provider, where I give you like a simple way to sort of focus more on what's right with this person as opposed to what's wrong with this person. So here's another just quick exercise. I want each of you who does take care of patients, to take someone you are currently caring for, and someone that you've struggled to meet their needs, someone that might, in our unfortunate lingo of the medical system, be labeled a difficult patient, might be labeled non-adherent, not invested in their care, but I'm going to say it very intentionally a bit differently. Someone who we're just not meeting their needs. We're not getting their addiction better. We're not getting their knee pain better. They keep coming in and out of the hospital. So see if you can actually come up with a concrete person in mind. And if you have something to doodle on, I want you to, in the next, to do good science here, I'm going to give you a very specific time, 45 seconds. I want you to put down as many things as you can regarding their medical conditions, their poor social determinants of health, and go for it. Social stressors, addictions. What do you know about this person? Okay, stop there. And we actually gave you a little extra time. Same person. Sorry, this little window. I don't know if you guys are seeing it too. Get rid of you. I don't know if you're seeing a square in. Looks like it went bye-bye. Okay, same person. Now I want you to list all the things you know about the same person, but this time in the realm of strengths that you see and know about this individual. So healthy habits, social support, personal characteristics like resilience, humor, and also, since we always mention social determinants of health in a negative, there are clearly for every human being social determinants of health that predispose to good health that we don't think about and we don't chart, we don't pay attention to. So feel free to write those. Go. Everything you know. All right, and stop. I gave you the same amount of time for question one and question two. So if there's maybe one brave person who'd just like to share what you take from that exercise, any any significant difference? Was your strength list much longer than your deficit list? Was your deficit list much longer than your strength list? The floor is open. I recently did this with a residency, and one of the residents, said, "Gosh, Mr. Jones has literally been inpatient for about 3 months now, and I couldn't answer question two." Isn't that a sad comment on like where medicine directs the conversation? Literally along one of those people you just can't find a good placement disposition out of the hospital. And so these residents have been rounding on the person, daily for months, and they have nothing here. They could easy question one, usually particularly because it's people we've struggled to meet their needs. Question one's list is much longer, and question two sort of again flexes that muscle that is atrophied, and we say, "Huh, yeah, I actually probably know very little." Guess what? Question two, because it's a patient who we've struggled to meet their needs. They're not getting better in whatever that looks like. Question one has nothing to do with how we're going to find the ahas. It's all about question two. It's all about question two. Maybe a family member we haven't engaged enough into because we haven't even asked about social support. Who are the 3 or 4 people that most support you right now? And maybe that's going to be part of the key, or just sort of empowering and uplifting, again, personal characteristics like resilience to overcome things. Question one, we say this is how we assess health, but I would say objectively, taking a scoping out, that anyone outside of healthcare would say this is not health. This is a very slanted, view, this is called deficit mapping. This is not a health assessment, but this is what all of our notes, all of our HMPs, all of our discharge summaries read as. They're not health assessments, y'all. They're deficit assessments. They're purely what's wrong with people. There is a place for that. There is a place for that, but it's exclusively what we talk about, what we document, what are our views and things that people tell us is what we should be working toward are about. So the pearl here is that what we pay attention grows. And so if we only pay attention to question one, that patient will continue to be difficult, non-adherent, and we will struggle to meet their needs. And it's only when we start paying attention to question two, what's going right? Like, that's the perfect person to go in the room. If that person is still someone you're literally going to round on tomorrow, what are you grateful for? I want to ask you a question. This might seem really a little different, but where is your health flourishing right now? Like, where that might take the conversation and where that might ultimately make a connection for the person and a connection between you, the provider, and the person, that's a ... and you'll have to see the good things that tend to happen when we do that. Also, sort of an interesting pearl, again, I'm using asset mapping and strength-based interchangeably, is that when we allow people to define themselves, they will almost exclusively use strength-based language. They will not use the deficits that look like this. Like, this is what Dr. Fleg writes or presents to my attending as a medical student. This is not, I guarantee you, how this human being, when asked, how would you describe yourself right now? That this is not how human beings describe themselves. So, yes, if we want the simplest, really simplest thing, asset mapping, strength-based medicine is listening more than talking, because the experts in what people do well and what communities do well are the people themselves. It's not us with our stethoscope around our neck. Also, and sort of along with that, the second point here is that it really changes the power structure, because if I go into the room with a 12-year-old for a well child visit and see the 12-year-old as the expert, it changes, right? It changes completely how I'm going to talk, how my body language, what I'm interested in getting at, in addition to, yes, screen time, yes, are you eating healthy foods, but also, for a 12-year-old strength-based question, in fact, let's just have fun for a second. 12-year-old well child visit, what are some strength-based questions you would ask this young expert in their own health and body? Feel free to put it in the chat or unmute. What would you want to ask them that's not on the normal, it's not on any question checklist of the CDC question developmental guidelines? Yeah, what would you want to ask this 12-year-old?
So what's like the best thing happening in your life right now? What are you most excited about?
Love it. Any others? Tell me something, Santa Fe. I worked alongside a strength-based nutrition, and she got so tired of having her parents just sit in the room and complain, my kid doesn't want to exercise, my kid drinks soda. So what she would do is she'd ask in each of these interviews, tell me something, mom and dad, that you're proud of about your 12-year-old. Strength-based. Okay, this is not going to be a put your kid down for the whole visit and no, what are you proud of? And for some of these kids, it was the first time they actually heard their parents say something that they were, really proud of about them as a young person. So again, what we call health assessments are really deficit assessments. We're great at mapping deficits. We take out names, we take out any humanizing characteristic, and we call that, effective and time effective medicine. we also do it in our sort of community health work. I recently looked at this New Mexico Hepatitis C Coalition. No offense if anyone on the call here today is part of this wonderful group. 40 pages. I read through every single word. I just wanted to see, could this group that by definition wants to improve the lives of those with hepatitis C, did they in any way care to look at what this community, this group has going for it as strength? And there was not a single mention in the 40 pages they had. Just a ton of deficit mapping. So I sort of question, can a group like that actually do ultimately good if they're coming from a deficit lens? Because I deeply believe that we can't. We can do some curing and some treatment. We might pass a policy, but I don't think if our work is only seeing people, individual patients, or communities like the Hep C community or a geographic community, if we only see it with those lens, I think we're doing more harm than good. So asset mapping is simply, or strength-based medicine would be identifying and then growing, amplifying strengths, assets, resources, resiliency factors, positive social determinants of health, and using that as our guide to improving health. Whereas our default that we've been taught and that our system sort of reinforces deficit mapping, where we exclusively want to know what's wrong, and then we think, and I sort of put in quotes here, that we can use that to improve health. Quick story, and then I'm going to open up for questions in a few minutes here. So this is my wife on our wedding day, the red earth of Tuba City behind us, her grandfather to her right in the red bandana, a Hatopli, a traditional healer who married us. And I know him just as Grandpa Bahi, many beads. He passed right at the beginning of COVID, from COVID. He was about to be 95. He was still leading all-night ceremonies and prayers as a medicine man. And I think of him walking into any of our clinics and things that very likely would be talked about, would be in the oral presentation, would be in the written note. And none of it, probably just seeing those words in front of us is necessarily jarring. But I want us just for a moment to think, what if we just took a strength-based approach, a lens, like literally put on glasses that were slightly different and saw fluency in an indigenous language as opposed to low English proficiency. In fact, it sort of makes it that our clinic is deficient in ability to speak in Navajo as opposed to it's on the patient and it's their issue. For anyone that would be curious enough to ask about what does being a traditional healer actually entail, you'd hear that Hatoplis like Grandpa Manybeads train often into their 50s before they're deemed by their mentor traditional healers to know the songs and ceremonies and prayers well enough to sort of, quote, graduate. So for all of us that grumbled how long medical training was, Grandpa Manybeads might have a third grade formal education, but that does not in any way capture how learned he is. 40 years of being an apprentice medicine man before you're a graduate. So many sort of things here. If any of us make it into our mid-90s, we're going to have many chronic health conditions, but we'd miss that he's leading all-night ceremonies and prayers at that age. And that level of functioning, I contend, is much more clinically important and clinically accurate than just that he has 18 things, arthritis of the joints and et cetera, that come with age. So Grandpa Manybeads, nothing changed about him. He's fine. He knows who he is, but this is just a lens that reflects the person writing such a note and writing these things. And this is similarly a lens that's different, and that I hope all of us here aspire to be this, to see this, to bring this out of our people and our again, for those who do community work like me in our community work, to similarly bring that out by not focusing on strengths again, as this example sort of shows, absolutely, it's medicalized racism. It's medicalized racism. I'm not even going to go into like, well, why didn't he get a formal education? Well, Grandpa Maybeads was born right at the time that the U.S. in 1920 decided to call Native Americans U.S. citizens. So he didn't just decide he was done with school. The U.S. never thought of him as fully human and fully citizen. So to hold that against him and to put in the chart low educational attainment has so many things wrong with it, including the whole angle that he's really learned it. He just didn't do it in a formal system. We dehumanize ourselves. We dehumanize the health professions. To Leandrita's point earlier, we lose a key chance to empower. I can't empower someone if I'm only focused on their out of control diabetes going into the room. I'm not going to be able to empower them around that. I can empower them by showing that I take interest in what's flourishing in their life, what they're doing well, and maybe trying to connect the dots. You know, you've told me your spiritual health is really strong right now. I wonder how we could use that to influence how you're taking care of your physical health that is really struggling. So I do real medicine. I just do it from a different lens. I'm going to sort of skip these questions. We can have fun here for a moment, put on some glasses that are strength-based. Community wants to work on addressing high rates of teen pregnancy. So from a strength-based approach, who are the experts we might want to engage, let's say in the coalition? Feel free to put it in the chat or...
Yeah. That's what I was going to say. Talk to the kids. And also, you know, like think about the other places that they are. I mean, you can talk to teachers, of course, but like for example, we have a really strong youth group at our church. And so I think our youth pastor would be an excellent resource because the kids confide in him. You know, they reach out to him when they need support. And so he would be a wealth of information, and just the people that work with them closely could give a different perspective. You know, parents of teenagers, perhaps. I'm thinking, you know, there's all kinds of people we don't often think about. Coaches. Um, yeah.
So who are the stigmatized people in this example in our communities? Teen parents, moms and dads. Teen parents absolutely have to be part of this group in addition to everything that we're saying. But let's make sure it's not the valedictorian youth for a token youth presence on the Teen Pregnancy Coalition. Let's make sure it's a teen parent, a mom and a dad who have from a strength-based lens, they have the unique perspective that no one else in the room, not the most world-renowned OB-GYN doc, school counselor, school valedictorian for that matter. We need teen parents, but teen parents would rarely in real life be invited to be part of such a coalition. So, okay, deeper level, really deficits are strengths in disguise. In this case, teen parents that might have been stigmatized by their communities, and all of what they lived through as teen parents are now the experts because they have a unique perspective on why teens get pregnant and what we might do if we did want to stop or lower rates. Interesting, just real quick sidebar here. My wife's community of Tuba City, Navajo Nation, had the Arizona Department of Health sweep in about 2 decades ago around these striking high rates of teen births. And what the wonderful people, well-intentioned, deficit-based as they are, Department of Health failed to ask, and again, just the importance of listening to people. Tuba City did not see teen pregnancy as a problem. Department of Health saw it as a problem. They saw rates on a piece of paper on a website that were far above, the state average. But when you start talking to people, if they might not define the thing that you might think the A1C of 12 is, oh my gosh, we got to stop everything and fix this. But first, does the person see their out of control diabetes as a problem? For a Native community that's been the attempt was to wipe them off the face of the earth. My wife talks about her grandmother when she became about 12 or 13, literally asking her, why aren't you having kids yet? Because procreation is sort of this resilience against colonization. Now, there's a middle point here, right? Like we're not in a farming and herding society where having 20 kids is quite, it's going to be really tough to raise those kids. But the point was that you can't take what you see on paper on a patient's chart, or in this case, a high rate of something, and assume that it's a problem until you ask and get a perspective. And you might see that from their standpoint, we're not going to get anywhere with talking about ways to decrease teen pregnancy if we don't recognize that from that community standpoint, teen pregnancy isn't an issue. It's not, they don't see it. They see poverty as an issue. They see lack of jobs as an issue. They see addiction as an issue in their community, but they don't see teen pregnancy as a problem. There's a huge disconnect there. So I'm going to just skip to the very end and tell you real big thank you for being here. Take care of people, not patients. Try to get life stories. Try to have people. Health statement for me is, in your own words, how would you, Mrs. Smith, describe your health right now? Physical, mental, spiritual, as opposed to me defining it or me looking in Mrs. Smith's chart and seeing how other medical providers might have defined it. Let them talk, because that's where strengths and assets will come out. Honoring that people and communities are the experts and not us. So I actually start my notes with wellness in my assessment plan. I'm waiting for the coder and biller folks. They haven't bugged me. I'm sort of surprised and a little bummed, to be very honest with y'all, because I'm sure they're like, what? How do we code for? I mean, especially if their algorithm says the first thing Dr. Fleg lists is the number one reason for the visit. Every one of my visits starts with assessment and plan wellness. I'm saying life's too short for me to do deficit-based medicine. Even if this person came out of the hospital 2 days ago, my note will start with wellness. It's my reminder that I can use the same intellectual rigor to assess this person's wellness as I can the things that are the medical conditions. And this was a real visit recently. I have fun with that. I have my students flex that muscle that's atrophied, and what? You want us to assess wellness? We don't know what you're talking about, Dr. Fleg. So this person is a real person, a really important person in my life and my career. His name is Raphael. Raphael is a Navajo gentleman who, after about 4 hospitalizations, he asked the nurse at about midnight, and 4 hospitalizations in a month when I'm an intern, way back in the days where I rode my horse up to the hospital and brought a lantern in to light the hallways. So he asked the nurse for a big pen, a piece of paper, and he draws this. He hands it to me as he's leaving the hospital. Raphael, in 4 hospitalizations, did anyone make you feel like a human being? No. Did anyone ask you, Raphael, what you thought the key to getting out of your alcohol dependence was? No. They gave me tons of talks on how I was killing my liver and a lot of lists of AA groups I could join. Raphael, if they did ask you, what do you think, as the expert, since it's your body and your life, what do you think is the key out of alcohol? Do you have any answer with that? Sure, I do. Yeah, when I do art, I'm sober. Real simple. When I do art, I'm sober. So we're not doing good medicine with the Raphaels of the world that keep coming in and out of our system, and that we're struggling to meet their needs, and then we grumble about how they're, horrible patients. We're actually making Raphael sicker every time he comes into our system that clearly says to Raphael, in many ways, you are an alcoholic, you are an alcoholic, you are an alcoholic, you are an alcoholic, and never asks him just the simplest question of, tell us, what do you think? We're clearly not helping you here. What do you think is the key? So this would be now doesn't take a whole lot more words. It communicates a very different thing though. The revised strength-based. Raphael's a 30-year-old Dene artist. He is here today for blah, blah, blah. And we have struggled to meet his needs in previous hospitalizations or visits. Raphael ends up going on to teach at our local healthcare for the homeless. He teaches classes on how people can use art to help them through their addiction and through their traumas. So again, his deficit becomes the specific way that he can connect with people who know homelessness, who know addiction, who know trauma in a way that we simply could not. So that picture has stayed with me for 2 decades. And I'm going to open it for a few minutes of questions. I do have a little survey if you're willing to share a few of your thoughts. That would be great. Share my email here in a second. I can also put into the chat a few of us, community organizer, elder, and a few of us in the health professions wrote a paper, Seeing People, Not Patients, and I'm going to put that into the chat as well. So questions?
If you bring back the previous, oh my, give me 1 second.
Unmute and you can, yeah.
If you put back the last slide, the way that you wrote it, I saw that. Go back. Yeah, I noticed the last sentence, we have struggled to meet his needs. So we are taking responsibility, we put it on us as physicians.
Thank you. You said it beautifully. No, you said it beautifully. And how is that different for you than if we don't think that or say that? For a person who's just cycled in and out of the hospital, doesn't get his antibiotics, starts drinking again, comes back in. How for you is that different and important to have that last sentence? Thank you for noticing it.
I do have a lot of experience in the ER, so I did see the recurrence, the revolving door, that patient just keeps coming in. And, sometimes we had a term, they're just irregulars, what we would call them. And so basically, but I had asked him the question, what can we do to help you? The reason why I would ask it was because they would come in, get whatever they needed to get. Sometimes, they were just, the medication, they just couldn't pick it up. They were homeless, or they just didn't have funds to pay for it, just whatever the case was. But in any event, we never went beyond just the moment, and we couldn't think long term on how to, physically help him, as far as, so that he has all the resources available, so that he has the opportunity to succeed on his own and take control of his life at that point.
And I tell this story because I was one of the guilty. I wasn't doing any better when Raphael in real life said not a single human of the hundreds that had interacted with him, from ER to being admitted over the 4 hospitalizations, made him feel like a human, starting with just all the people who stand over his bed and look down on him, literally and figuratively, that I was no better. I still to this day really am not quite sure why he handed me the gift, the piece of art, the awakening. Hey, you didn't see me, but here's me. I'm not just a person who drinks alcohol. And to your point, we didn't go deeper, even though we had all these hospitalizations, that it was really him being far removed from his home community in the big city, depression, the stressors of being homeless, and how is he going to put his leg up even if he does get his antibiotics. I mean, all these layers, we just really, I think, got comfortable in stigmatizing this human in the one place in a healthcare setting where we aim to not stigmatize people that walk around in their other parts of their life feeling that scorn and that stigma. And we were heaping it on. And he almost said, despite you all not seeing me, I'm going to break out of the shell and figure out, because no one here seems to care about what I think is the key. I mean, he's so like so articulate. When I do art, I'm sober. And here we are giving him these ineffective lectures. This is where sort of the deficit lens just leads us to bang our heads against the wall. Why is this person not getting better? And it's not the person. We're struggling to meet their needs because we're seeing an addict, we're seeing a patient, we're not seeing a whole person. So I really encourage you on that exercise of someone you feel like your team or you personally has struggled, the name that when they come up on your primary care, clinic list, your heart sort of, does a little something like that, is your great next chance to do some strength-based medicine and really change what that relationship looks like and watch how you become a more effective clinician, and then watch how you actually walk out of the room and not feeling depleted or defeated. You actually feel like you did something, and you learned something, and you learned something about yourself and what it is to be a healer. So I'm really excited for y'all to do some practicing. My email's in the chat. Any last comment?
This is great. Thank you so much.
Yeah, if you feel really wild, I also have in my HPI, just knowing that Anthony still works in a sick care system that could care less if I look at wellness or pay attention to wellness. I start all my HPIs with wellness. It's in my template. So just as a really simple way, however you create your notes, find ways to make it easier, not harder for you to be strength-based. And by it being there, like there's occasionally times where I didn't ask anything about that person's wellness. But it's at least in there in my note to remind me that, okay, well, I missed it, but next time, definitely. But yeah, it starts my HPI, and then it starts my assessment plan is assessing wellness. Someone can be really sick and be really well at the same time. Sorry, that's a whole nother talk, but we're really looking at two very different dimensions of a human being. When we look at wellness, you can be well and you can be sick, and you can probably think of someone who has maybe a terminal illness, but is spiritually grounded, has great social support, is eating well, is exercising. Yeah, they're well and they're really sick. And they're two very different things to look at. One of which, the sickness, our medical system teaches us to focus on, and one of it, wellness, our medical system has unfortunately put some lenses that we're going to try to sort of lift off of our eyes, that are the deficit lenses that keep us from seeing those beautiful other parts of the human. Mario, thank you so much for having me. I'm excited to join some as a participant in the near future. I did put the survey link in the chat as well, and just appreciate you all. Be in touch. Let me know if you have any ahas once you start going out and practice. Thank you to the residents. Sorry that we're teaching you deficit-based medicine and you're in a sick care system. I can't fix it, but you can fix it from the ground up.